Hello, and thank you for joining this OncLive peer exchange titled The Era of Targeted Therapy for Acute Myeloid Leukemia. In recent years, we have made considerable progress in learning about the pathogenesis of acute myeloid leukemia, leading to the very recent FDA approval of several novel targeted therapies, with more on the way. In this OncLive peer exchange discussion, we will discuss the incorporation of new treatment options into clinical care, the promise of minimal residual disease testing in optimal managing of acute myeloid leukemia, and emerging strategies for improving patient outcomes. We'll review the data from the ASH 2017 annual meeting and how the newest research will impact the way we treat our patients. I am Dr. Harry Erba, and I am the chair of the SWOG Leukemia Committee and professor of internal medicine at the University of Alabama at Birmingham. Participating today on our distinguished panel are Dr. Jorge Cortes, Chief of the CML and AML sections and Deputy Chair of the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. Dr. Sasha Perl, Associate Professor of Medicine in the Leukemia Program of the Division of Hematology Oncology at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, and Dr. Eunice Wang, Chief of the Leukemia Service, Professor of Oncology in the Department of Medicine, Roswell Park Cancer Institute in Buffalo, New York. Thank you so much for joining us, so let's begin. So in recent years, with the development of next-gen sequencing that is more rapid and less costly, we have learned a lot about the molecular drivers of acute myeloid leukemia. Sasha, can you bring us up to date on that subject?
Sure. I think there's been a nice summary of this published by Ellie Papamanuel and colleagues from Memorial Sloan Kettering, looking at the genetics of AML, really expanding upon the huge effort done by the TCGA, the Cancer Genome Atlas project. And what Dr. Papamanuel did was basically did sequencing of over 1,500 patients treated on German cooperative group studies, looking to categorize the molecular lesions found into functionally important and hopefully non-overlapping categorizations that you could use to define patients, patient groups, and hopefully prognostic information. And she found that basically you could segregate patients based on a number of factors. And there are three that really emerged, two of which we can look at karyotype, and one comes from gene sequence mutations. So the first are patients who have gene fusions. And these are things that we know, like we think of APL as being AML with a translocation between chromosomes 15 and 17. So these recurrent genetic aberrations we already have defined, but she was able to break that out into recurrent gene fusions. The next group were patients who had aneuploidy, which often was seen in the presence of TP53 mutations. And these patients had chromosomal abnormalities, but these are the patients that we treat who have often very complex karyotypes, and you get a cytogenetics report back, and it's a whole page of abnormalities. Deletions, monosomies, things like that. And the last patients were generally patients with very few cytogenetic abnormalities, but often a number of gene sequence mutations that were highly recurrent. So in this study, there were over 150 targeted gene sequences that they looked at, and they found mutations in the majority of those genes, but each patient would perhaps only have maybe 3, 4, or 5 mutations in their leukemia present at diagnosis. But looking at the patterns here, they were able to segregate patients out into defining features even within this, and some of these are mutations that we're very familiar with, nucleophosmin being one, CEBP alpha double mutations being another. There's another group that have mutations that alter either the spliceosome complex or alter the chromatin remodeling. So there's a group of patients that have different functional mutations, but very similar prognostic grouping. And from this, she could basically define out, I believe, 11 different categories of patients based on where they fell on that, whether they had recurrent gene fusions and the specific lesion, the presence or absence of aneuploidy being a defining lesion, and then if they had gene sequence mutations, where they fell there. And that was highly prognostic for how patients did. This is a huge and very complicated study. But it really is interesting because if you look at the patients, especially in the third group who had gene sequence mutation, it goes way beyond what we currently have for prognostic models because it can look at not one gene mutation that's prognostic, but combinations of 2 at a time or 3 at a time to say how patients will do. And that goes beyond our current prognostic categorization, either by the NCCN or the ELN guidelines. And so that I think is notable because it's those combinations not of just one gene, but several genes together that really tell how that group is going to do.
What I thought was interesting about that analysis is that some of the data was quite consistent with data coming from other studies.
Yeah.
So for example, the group of patients that you identified, or she identified from that study with mutations in the genes for spliceosome enzymes and chromatin modifiers, that same group of enzyme or gene mutations have also been identified as being more specific, if you will, for secondary acute myeloid leukemia, based on the data published by Coleman-Lindsley from a prior study of secondary acute myeloid leukemia. And then the other thing is when we look at clonal hematopoiesis of indeterminate prognosis, those are the same classes of mutations that are occurring and may underlie some of the explanation of why our older patients who finally develop acute myeloid leukemia are doing so poorly.
Yeah, and certainly if you look at the gamut of who winds up with which lesion, older patients are much more likely to wind up either with that third group that's defined by specific gene mutations, and often that arises out of clonal hematopoiesis of indeterminate potential, or we just call it CHIP, or they're patients with aneuploidy and P53 mutations. And yes, you can see secondary leukemias or secondary myeloid neoplasms with either of those two groups. You can actually see them with the gene fusions as well, often after topoisomerase II poisons or anthracyclines.